All right. Good afternoon, everyone. Welcome to our next panel, now that everyone knows how to hack if you need to. Thanks to our prior presenters. That was really interesting, and I even learned a lot as a layperson, so I really appreciate your being here. My name is Elie Honig. I'm the Executive Director of the Rutgers Institute for Secure Communities. Again, I want to thank everyone for being here. Our next panel is on the topic of opioids, combating the crisis with data. And I will tell you that having been with the AG's office from 2012 until just a few months ago, the opioid crisis is one of the problems that have really emerged and has come on with incredible swiftness and lethality. And it really has confounded, I think, law enforcement, intel, and medical professionals alike. There is no single cure. There is no silver bullet. And despite the concerted efforts of really all 5 attorneys general that I served under, that Colonel Fuentes served under, the problem persists. That's not for any lack of effort. That's not for any lack of creativity or ingenuity. It's just a truly complex and vexing problem. And I do think perhaps there's some hope in using the analytics to find some angle from which to attack this. So we have I think, a very interesting and certainly a multidisciplinary panel pulled together here today. And what we will do is each of our 4 panelists will present. I may have some questions, but once each of the panelists has presented, we'll go into Q&A. So we welcome questions from the crowd, and we can sort of make this a natural, free-flowing conversation. So our first speaker is Dr. Nima Majlesi. Dr. Majlesi, like me and like Ava, is a graduate of Rutgers College. And Dr. Majlesi also is a graduate of the New England College of Osteopathic Medicine. He has a whole bunch of other impressive medical credentials, which I won't just read to you verbatim. You have it on your sheet in front of you. He is also, importantly, Ava's big brother. And their father, Mr. Majlesi, is here, so quite an impressive family. Welcome. We can give him a round of applause. One child's a doctor, one's a lawyer. That's pretty good. Sorry, I had to do it. Dr. Majlesi is going to give us his perspective as a medical practitioner from sort of the ground level of the problem as he sees it. So, Dr. Majlesi.
Thank you. Thanks for the introduction. Thanks for having me here today. So, I think what I wanted to talk about today is essentially how we can use data as an antidote for this opioid epidemic. I'm on the front lines really taking care of this on a daily basis, taking care of real people, and also at the end of the day, I also work with public officials in terms of trying to help with public health issues. So when you look at the opioid epidemic, if you want to try to put it on a scale, it's actually exceeded the AIDS crisis from the 1990s in terms of how much mortality we see from this. It actually has surpassed it in terms of the severity. If anyone can remember, most of you guys, a lot of you may be too young to even understand what that means, but for the people in this room who lived through the 1990s, it's a big deal, right? Opioid-related overdose deaths, you look from 1999 to 2014, skyrocketing, exponentially going up every year. In the United States, look at what happens. Any opioids, and then there's this little blip where all of us, that's been going up for quite a while, and then all of a sudden now we're seeing a lot of heroin and synthetic opioid-related deaths also going up. Death rates from overdoses from heroin or prescription opioid pain relievers by age group. Look at the age groups that are being affected by this. This is data that's really important. From the ages of 25 to 55, these are the people who are really suffering and dying. Very unusual, right? This chart, I just wanted to go through these real quick. The more red it becomes, the more concentrated and higher the volume. So look at admissions to hospitals by state over the years, right? This is 1999, 2001, 2005, 2007, 2009. A great graphic just to show you how much increase we're seeing in terms of admissions to hospitals related to opioids. Big deal. All-cause mortality, ages 45 to 54, U.S. white Hispanics, non-Hispanics, and U.S. Hispanics. So look at every country. There's been a good improvement in terms of mortality. Everyone's mortality is, people are living longer, we're improving mortality deaths. There's only one group that seems to not really be doing too well in that graph, right? It's U.S. white people, white people who are in the United States. That has gone actually up mortality. Interesting. So people were like, what is this about? We don't understand this. Why is this happening, right? U.S. Hispanics are, they're actually living longer. France, Germany, everywhere else is doing pretty well. And what you find actually is that non-Hispanic white people are basically dying from opioids, essentially, at a young age. And this was very interesting. And when you look at, white people, and admissions, non-heroin opioid treated admissions in 2013, look at these spikes. No other group is spiking like that. So data is really important in terms of helping us figure out where this problem is coming from and who's being affected by these problems. Mortality by cause, white, non-Hispanics. Look at this, poisonings skyrocketing, right? Look at what parallels poisoning, suicides, chronic liver disease. We're doing better when it comes to other things, lung cancer, heart disease, but poisonings skyrocketing up. So in parallel with that US white increase in death rates. Unintentional overdose deaths involving opioid analgesics, they actually parallel the sales of opioid analgesics. We found this, right? So as opioid sales go up, so does mortality. So important data. This is also a good kind of just graph just to look at also sales of opioids, opioid deaths, and opioid treatment admissions, right? So again, in parallel, the more we sell, the more opioids pharmaceutical people sell, the more people die and end up admitted to the hospital. Look at the consumption of oxycodone in New York, skyrocketing in 1996. Same thing with hydrocodone, skyrocketing in 1996. This is important data. All these things paralleled each other, and it helped us figure out where this problem is coming from. Interesting data right here. Dollars spent marketing OxyContin. Also, look at this over the years. There's a reason that this happened, right? They're making a lot of money off of this, and unfortunately, people are dying from it. Important to understand the pharmaceutical industry funded message. When I was a resident, this was quite a while ago, I'm embarrassed to say, when I was being trained as an emergency physician at that time, I was taught opioid addiction is rare in patients with pain. I was taught opioids can easily be discontinued. Opioids are safe and effective for chronic pain, actually. Physicians are needlessly allowing their patients to suffer in pain due to fear. The Joint Commission at the same time, which is a government agency, came out with pain should be the 5th vital sign, not just heart rate, things that we normally use in medicine to determine how sick people are, heart rate, blood pressure, how well your oxygen is saturating, all these things that we look at that are important. They said pain is also really important. So part of the patient satisfaction surveys after they go to visit us as a doctor was, did the physician adequately address your pain, right? And your accreditation as a hospital depended on meeting certain standards, how well you treated pain. I'm hoping this will work and be quick, just so you can kind of get an idea of what the message was from opioids by the pharmaceutical company. I don't know if you'll be able to hear this, hopefully. Pause it? Sorry.
Okay, try it.
If you can't hear it, it's
No question that our best, strongest pain medicines are the opioids, but these are the same drugs that have a reputation for causing addiction and other terrible things. Now, in fact, the
Can you guys hear this?
rate of addiction amongst pain patients who are treated by doctors is much less than 1%. They don't wear out, they go on working, they do not have serious medical side effects, and so these drugs, which I repeat are our best, strongest pain medications, should be used much more than they are for patients in pain.
This was the message by the pharmaceutical companies to physicians. And physicians love to be fed data. In fact, everything that we do, in terms of every time I see a patient, it's based upon data in my head. How likely is this patient to get sick from this disease? What's the risk-benefit of treating this problem? Everything I do is based upon data, actually. Where did he come up with that statement? There's no data to support what Purdue Pharma was supporting at that time. It's one little blurb in the New England Journal of Medicine based upon, I would say this is not an adequate study, a paragraph. Okay, this is not a study. This is a paragraph. This paragraph, to me, is probably responsible for more deaths than probably anything written in mankind. I mean, seriously, millions of people have died probably because of this statement, which essentially says that we have had 11,000 patients who have received narcotics and only 4 of them have been addicted or dependent on these drugs. That's crazy, right? That's completely false. That's not normal. That doesn't make any sense. And when you look at the data for long-term opioid treatment, over and over again, the studies show opioids are not a good treatment for chronic pain. They don't work well for chronic pain. We should not be using them for chronic pain. Effectiveness and risks far outweigh the benefits of opioids for chronic pain. Controlling the epidemic really has required a 3-pronged approach. Preventing new cases of opioid addiction, right? How have we done that? We've basically implemented policies to try to limit the sales of opioids, the prescribing of opioids by practitioners, being a little bit more intelligent about the way we prescribe these things, treating people who are already addicted with multi-pronged approach, which is very challenging, medication-assisted therapy, drug counseling, those kinds of things, and reducing the supply from pill mills and the black market. DEA has been following this data for a very long time, and we know that over 2013 to 2014, greater than 700 fentanyl overdose deaths. And then you can see, again, data showing fentanyl deaths up 540% in 3 years. Weird, right? All of a sudden, deaths are now related not just to any opioid, but really fentanyl is becoming the #1 cause of deaths. So you can see the epidemiology is changing a little bit here. And counterfeit pill mills are really fueling this epidemic at this point. This is a normal oxycodone 80 milligram tablet compared to the counterfeit tablet, which is actually fentanyl. So what these people are doing essentially is they're shipping these synthetic opioids from overseas, mostly from China. Not to blame China for everything, I'm sorry. Right? And these places, basically, there's these nasty machines where they're making these counterfeit pills that look like oxycodone. So people think they're going on the street and they're buying oxycodone to get high, but actually what they're taking is fentanyl. They never even knew it, right? Low risk, high reward, just in terms of sales, right? When you think about how much money these people are making, we're talking about enough to make me want to quit medicine. A lot. All right. But the point that I'm trying to say is that data is very important in terms of following this epidemic. We really have been able to figure out a lot of different things in terms of what's happening. And so as a physician, it really has helped fuel us in terms of the treatment of the opioid epidemic. I'm happy to, there's a lot more obviously involved in this. I'm happy to answer any questions on the panel, but that's where I wanted to leave it. Thank you.
Thanks. Yeah, you can just leave that. So, Dr. Majlesi, I'm just going to throw one question at you for now, and there may be others later. Can you talk to us about whether doctors, in your experience, are changing the way they prescribe opioids, painkillers, either formally, whether, I don't know whether there's been new guidance issued, new policies, or informally, just day to day?
I would say the answer to that question is absolutely yes. Mm-hmm. I don't think doctors want to kill their patients. That's certainly true. We try to do things that are based upon data. We try to do things that we think are best for our patients. And I think with all of the data that we have, we've actually been able to influence prescribing amongst physicians. So we have lots of guidelines by national organizations. We have lots of government guidelines out there. We've created things like iStop, which are basically places where you can look and see how many prescriptions patients have received over the past few months and things like that. And with those guidelines, we've actually been able to improve, I think, some of the things. And when you look at just places, little places like for example, where I practice in Staten Island, we have seen decreases in deaths. We have seen decreases in admissions from opioids. The epidemic is obviously still vast, and there's a lot of problems which we can talk about. I know a lot of people are involved in this room. In terms of the opioid epidemic, there's a lot of problems in dealing with these issues that are much different than the AIDS crisis, right? We're talking about people that were fearful and wanted treatment, and not to judge the opioid, misuse population, but very resistant to treatment. So you're talking about two vastly different groups who, essentially.
Okay. So. Good. Thanks, Dr. Majlesi. I think we have sort of the perfect transition here. Dr. Majlesi mentioned fentanyl a couple of times. Everyone here, would just show hands. Does everyone know what fentanyl is? Okay, almost everybody. It looks like everybody. I'll tell you that, I was a prosecutor from 2004 until a few months ago. If you had asked me when I started at the AG's office in late 2012 whether I had heard of fentanyl, I don't think I had as of 2012. I don't think it was a term that I ever had heard of. It was certainly not something we were recovering as law enforcement agents off the streets. But by the time I left a few months ago, we were routinely grabbing quantities of fentanyl. We grabbed 35 kilos in a case here in New Jersey right before I left. The kilo is 2.2 pounds. It's a brick like this big. Just to give you a sense of what a sea change that is, here's how lethal fentanyl is. We had cases where police officers were overdosing, not dying, but having overdose symptoms from skin contact, from picking up fentanyl that they seized in cars with their hands, even through gloves occasionally, and having overdose symptoms. That's how lethal fentanyl is. And now imagine a brick of it, 2.2 pounds times 35 bricks. And you'll see the press releases that we did explaining that this could be enough to kill the entire population of New Jersey if you sort of do the math on it. On that note, let's sort of take a look from a law enforcement perspective. State police here in New Jersey, of course, have been leaders in this effort to fight the opioid addiction crisis, and Colonel Fuentes, we're privileged to have him here. Colonel Fuentes was in charge of the state police. I do think you retired with that distinction that you want. I know you wanted, which is the longest serving colonel. Second. Oh, you didn't quite get it. All right. Second longest serving colonel in the history of the state police. So please join me in welcoming Colonel Rick Fuentes.
I'm not Rick Fuentes. I'm just switching presentations.
Sure. Incidentally, I would never take that distinction away from H. Norman Schwarzkopf Sr. You might have heard of his son, but his father founded the state police, and he had 15 years on. So, yeah. So I'm thinking about what Ron said before, and it caused me to muse a little bit to a different era of intelligence gathering. So the starter kit for an intelligence bureau detective back in the early 1980s was a flip chart and a black magic marker, a trunk full of Hagstrom County atlases, and a payphone. Okay, the latter two, you needed to go out because that's the way you did your business and gathered your information. The third is so you could explain it to everybody else with a flip chart. So intelligence back then was palpable. It's digital now, but there's something to be said for the process, because I don't know that the process has fundamentally changed. It was that intuitive process, Ron, that you referred to. So no answers coming back to you. You had to sort of develop it yourself. But not many people in the room probably went through that era. I see some heads bobbing. Most heads are just quizzical, okay, not knowing what I'm talking about. Probably when I mention payphone, nobody knows what I'm talking about. But that was a big shot when I got a beeper. So, but following on the doctor's presentation, I thought I'm kind of the lead act here to Lieutenant Colonel Fritz Frage, who just got promoted to Lieutenant Colonel. Congratulations, about 2 to 3 weeks ago. He's now the ROC Task Force Commander and Director, which is no small job, very much an outreach position. A lot of information gets passed around. He's going to talk to you about the Drug Monitoring Initiative, which is a big data issue and fits exactly into the reason this colloquium was put together. What I find when I do these presentations, less now than when I was superintendent, is there isn't an understanding of what the actual market looks like. Like, how does the heroin get onto the street? So what I'm going to do is give you about 9 fairly rapid slides, and I'm going to walk you through the actual process of putting a brick or a dose of heroin on the street, and I think that'll segue nicely into what Fritz is talking about. So here in New Jersey, and obviously, heroin and fentanyl was mentioned. You're going to hear a lot more when Fritz gets up here about it. That's become the real problem in the last few years, in the last 5 years. But it drives everything. It drives violent crime in the cities. It drives property crime in the suburbs, and overdoses. Now, there was an opioid summit yesterday in East Brunswick. I think Governor Christie was there. Attorney General Grewal was there, and several other people that were talking about this. Star Ledger had a nice article on it this morning. So every year we're seeing this uptick. So 2 years ago, it was about 6 people per day were overdosing in the state. Last year, it was 7. That was the data that I was using. And this morning, I learned the number is up to 8. And it's trending towards 3,000 people a year. And it's probably going to be upwards of 60 or 70,000 people across the country. And the doctor mentioned the AIDS crisis. Okay, this is really exceeding most of the health crises that we've seen in the past. And it's not showing any sign of abating. Information sharing and some of the things I think Fritz is going to talk about are going to be key to this. And his presentation is going to be very grounded in that regard. But I want to show you the economics of heroin distribution here and just follow along. So I'm going to go kind of quick, give him as much time on this as possible. There's no doubt that it has, because of price and purity, replaced cocaine distribution. That's heroin and now fentanyl. Not just purity, the cost is about $5 to $10 a hit. Cocaine, we actually were winning the war against cocaine with the Colombians. The DEA person here can probably tell you that. There was a tremendous eradication campaign down in Colombia. The hectares of fields that were being, coca fields that were being destroyed was astronomical. Colombian army didn't want to fight the traffickers on the ground, but they were fighting them from the air. But what happened is about 2 or 3 years ago, the World Health Organization decided that the herbicide that was being used to kill the coca crops were making the drug traffickers sick. So they banned the herbicide. Now the hectare population has come back, and on top of what we're talking about, you can expect a cocaine explosion once again, presumably a lower price variety of that. The largest profit margins are not, it's when actually the kilos of heroin get here to the state of New Jersey, and it's the cutting it up, putting it on the street that are actually the largest profit margins. If you do a raid, you do a search warrant, most of the rest you're going to come up with heroin now, far more than possibly any other drug with the possible exception of marijuana. Price of a kilo from the cartel to the drug trafficking organization is about $48,000 to $52,000 now, and at the retail level, a kilo is $55,000 to $65,000, dropping fast. That's 25% less than it was 5 years ago. When we talk about the comparison of fentanyl kilo prices, you're going to see why fentanyl has come onto the scene in the way that it has. So this is an actual image from a cell phone that was taken off a drug trafficker by a state police raid a couple of years ago, and it really does highlight some of those prices. Normally, they're not engaging in these communications in a way that they can be seized, but here they're actually saying it's $62,000 price of a kilo. To here in New Jersey, in the Bronx, $60, and in Boston, it's $70. So it's a matter of the transportation route, the extent of the network, how easy it is to get it there. So let's just talk a little bit. Where does it come from? No secret, the Mexican cartels are producing this in bulk right now. Sinaloa is still at the lead, but the other cartels are obviously also involved. So it gets here by way of crossing the border there. It used to be hand carries back in the day. This is actually a lot of heroin here. But a kilo or 2 kilos, if you seize that amount of heroin, it was, I mean, you remember the movie The French Connection, so that was a big deal if you got just a very few kilos of heroin. Now they're getting hundreds of kilos of heroin in a seizure. And as Elie pointed out, they're getting dozens of kilos now of fentanyl, which you never really saw before. Now it's jumped to commercial vehicles. This is very, very dangerous, and it follows the trend of cocaine transportation back in the day. Once it jumps to commercial vehicles, it means that you're delivering in larger quantities than can safely be taken by hand or in a passenger vehicle. Okay, so it has made that jump. I'm going to take you just to a place in Teaneck. So this lovely house in the suburban area of Teaneck, about a $550,000 house, was occupied by 2 members of the Sinaloa cartel. They were receiving shipments. They were very, very quiet, no issues in the neighborhood, nothing on the police blotters, absolutely no problems, and they were actually receiving the kilos. So you can see here that you just don't know who's living next door in some respects in terms of this happening. And North Jersey is still a hub because it was a hub for cocaine and for some other drugs. So the existing networks that were around during a cocaine explosion of the 1980s and 1990s, those networks and that infrastructure is still out there, and as a result, those infrastructures are continually being used in heroin. Let's take a look at the startup costs. So you're renting a suburban location, let's say in North Jersey, you're paying about $3,000 a month or $750 a week. You got to go out and you got to buy a vehicle because you got to move a smaller quantity, probably no more than a kilo or 2 or 3, certainly under 5 at a time by vehicle to the people that are going to be actually cutting it and packaging it. You have to trap out a car to do that. It's not like you're putting it on your front seat, right? And you have to have a driver who gets about $1,000 every time he takes 2 to 5 kilos to a location where it's going to be cut. These are all startup costs for the drug trafficking organization. So they call it a milling site, very much a tabletop operation. They generally don't have a lot of heroin that you'll see in these sites, maybe 3 to 5 kilos. They don't like, this isn't a place where they stockpile it, it's the place where they cut it. So 3 kilos of heroin at about $210,000 per week, 3 kilos a week. Then you've got your mill supplies you need to get, coffee, grinders, heroin cut, which in the overwhelming number of cases now is fentanyl, tape, rubber bands, wax folds, stamp ink pad, and masks. That's about $1,700 a week. Then you got to have the people to do this, and this is a tabletop. Okay, you want to talk about a routine task. This is it here. Okay, packaging heroin, bag after bag after bag. Labor, they put about 6 mill workers around that table on a 6-day work week. They may work for one network, but if they're not getting enough work for one network, then they'll go and work for another network for a couple of days a week. This is an industry. This is, the people that are doing this are, run the gamut, okay? They get involved in these networks and they do it. That's about $10,800 a week. This is what basically a tabletop looks like. You see the chairs are all pillowed up to be very, very comfortable. They're sitting there literally for 12 hours a day. They're not stopping. Sometimes they're sitting there in their underwear. And the reason they're sitting there in their underwear is because the person who's running that mill shop wants to make sure that they're not stealing any of the product. Another thing you're going to see is a lot of Red Bull around, because the thing here when you're doing a routinized function like this is to stay awake. So they're constantly drinking power drinks. So let's take a look at the weekly output and the profit. 3 kilos of heroin produces about 120,000 folds or decks. That's about 2,400 bricks. Incoming revenue from the sale of those bricks, they're sold in 100 brick lots, $150 a brick, $360,000 a week. The profit margin, $360 less the $224 of your weekly expenses to buy the heroin and everything else and all your supplies, basically brings it down to a bottom line of about $136,000 plus or minus on a weekly basis. What's the impact of heroin distributed out of New Jersey? And this is the sphere of influence in distribution. All the way up through New England, down almost down through the Carolinas, some of the Carolinas, and west all the way out through Ohio. That's a pretty big sphere of influence where heroin has been seized, that has been packaged, milled and packaged in the state of New Jersey. Here's why you see fentanyl rising the way it is. So if you take a look at the prices here for a kilo, an ounce, and a gram, and a bag, and then look at the corresponding prices for fentanyl, it's only $3,000 to $7,000 for a kilo of fentanyl, and you can see that proportionally on down the line. So quite a bit of difference, and I'm going to show you something in a minute here where this is where fentanyl becomes very, very dangerous. It used to be where most of these purchases were made via the dark web. They were coming from outside the United States. Now, based upon what Elie was saying, is this is coming in bulk from the Mexican cartels, just like heroin is, and following those same transportation routes. And that's a real problem because they're seeing it not only cut with fentanyl, in some cases they're seeing pure fentanyl. And fentanyl kills you dead immediately. So it's a problem, obviously, for users, and it's a problem for law enforcement that has to deal with this. So the NJSP strategy, I just checked with Fritz, it hasn't changed in the last 6 months, but it starts with a strong partnership with DEA, EPIC, and the Honig groups. There's about 70 troopers that are assigned to the Transportation Safety Bureau and Mobile Safe Freight. We had EPIC, the El Paso Intelligence Center, which is sort of the DEA warehouse of information that they share with local and state law enforcement out in El Paso. We brought them out to instruct our troopers in 2016. As a result, our seizures went up about 600%. We x-ray trucks now, okay? So trucks that are suspicious get pulled through. It isn't like that heroin you saw on the back of the truck. You don't want to have to crawl down a refrigerated load to try and find a recess. in the cargo where this is hidden, so they actually use x-rays now to determine where those recesses may be in the loads. There's about 40 detectives that are assigned north and central and south trafficking units. So let me ask you, is that heroin, fentanyl, or cocaine? Because if you know more than I do, and probably more than Fritz does or anybody here. You cannot tell, and this is the fundamental issue right now with law enforcement. It used to be where you kicked the door based upon a warrant and you went in and you conducted a raid. Now this is what they look like going in, if they know it's going to be a drug raid. Our teams units on the left there, masks, are not necessarily detectives, but people from hazmat that are going in behind the teams unit here and handling the substances. Well, as you know, you need to get a warrant. If you're a prosecutor, you need to get a warrant to further your case. The problem is now it's the testing of the fentanyl. You can't just do a field test for fentanyl without killing yourself for the reasons that you've heard. And I think two of our detectives had a Narcan themselves. They were also exposed sometime within the last 6 months or so. So they got these glove boxes where they can do field tests back at certain areas around the state. Fritz, would they get about 20 or 25 of these glove boxes? So it's still being done by somebody from hazmat, but it's greatly reduced the amount of time you can get a positive on fentanyl or on heroin, and you can use that to get a warrant to be able to expand your case. So that brings me to the part where I think it really fits into this colloquium here, which is the big data issue of what do you do with all the information that's coming in about the heroin and the fentanyl problem in the state of New Jersey? How does the state police manage it? And the person probably best to talk about it is Fritz. Thank you all very much.
Use that, or you can use the arrows. No.
Okay, now I got it. How you doing? My name is Fritz Frage, and I'm assigned to the Office of Drug Monitoring and Analysis prior to being promoted to Lieutenant Colonel of the ROC, in a sense. So drug monitoring analysis is also known as a DMI unit. So to piggyback off of what Colonel Fuentes just stated, we're going to go over today is basically on data, how we use data, but you're going to learn what DMI is, what data do we collect, how we use the data in a sense. So I have 10 minutes, so I'll cut some investigative support stuff out just so you can see the point of today, which is big data. All right, basically, layman terms, what is DMI? What do we do? Basically, we're here to analyze data to give our decision makers information on the drug environment and probably most likely instruct them where to go, how to target this drug epidemic in a sense. Intelligence-led policing is the largest factor, and the information sharing environment that we've started in the state of New Jersey is the largest factor in combating this drug epidemic and all crime in the state of New Jersey, from crime analysis to drug analysis. And this is the component. Basically where you have intelligence-led policing with prevention, law enforcement, and treatment, and these are the entities that are involved in the data we collect. Our largest supporter, health has that information, the medical examiners, toxicology report, hazmat that goes out, and DEA, as far as the Office of Drug Monitoring Analysis, is probably our largest partner with personnel and support to combat this, this epidemic in a sense. These are the data sets that we use, and this is where we store all the data at the ROC in a sense. It starts off with crime, which is all crime data from drug arrests, property theft, with drug sheeters, lab results, law enforcement Narcan, which I'll show you the stats on those, shootings, and gun recoveries. And on the health side, we're limited to what we can get because of HIPAA requirements, but what we do get assists us in analyzing the data. These are the numbers that you really gotta focus on. Increased 66% from 2014. This is drug-related death. 66% in 2 years. The amount of people dying from drug overdoses. NJCares, which I'll show you in a few minutes, their website, they're going to show you all the Narcan deployments and toxicology reports for the past couple of years, and they predict that, that the average is 8 deaths per day. Colonel Fuentes informed me that it was 6, then last year was 7, now it's 8 deaths per day due to overdose in a sense. Fentanyl, 282%. I'm highlighting them in red so you can see what fentanyl, and I'll show you in a graph later on when fentanyl came on the scene. And 52% of suspected heroin now submissions have fentanyl, compared to approximately 2% in 2014 when it first came out. This is in reference to, anybody know what naloxone is, naloxone deployments? Naloxone is when you're overdosing. It's almost like a miracle drug that brings you back when you overdose. In 2014, naloxone has been administered over 45,000 times. In the first 6 months of 2018, 7,812 to first responders and law enforcement. It's 47 times per day somebody is getting hit with naloxone due to an overdose. These are the overdose trends you got to worry about. Look at from 2010 to 2014, mostly heroin. Pills, even in the press mills, they're using heroin. In 2014, fentanyl came on the scene. Look what happened all the way up to now, 2,900 cases. These are the numbers of the total deaths from 2014, 15, and 16. 46 were fentanyl related in 2013. In 2016, 982 of the deaths are related to fentanyl, compared to the 1,232. So the number has increasingly jumped, and I'll explain later the causes for that and the reason. This is the percentage of increase, 44% increase in 2016, and it's going to be a lot more this year. These are the second quarter of 2018, 52% suspected heroin submissions contained fentanyl, from 2% in 2014. Fentanyl is a potent drug. Colonel Fuentes informed you briefly on law enforcement contact with fentanyl. We've had a trooper that was involved in a raid in Trenton. He goes back to the office, gets exposed, touches it at some point, doesn't realize he touched it. He goes home, he's about to pass out. He injects himself with naloxone and drives himself to the hospital, and it was an overdose. And he wasn't trying to, just being in contact with it, touching it. You know, you touch it, you put your hand in your mouth, that's, you know, open space, it can affect you drastically. We just had a recent case that happened last week, as a matter of fact. Motor vehicle stop, somebody had a first aid responder. He passed out. Troopers assisted him. They searched the car. They found some powdery substance, brought it back to the station. Somebody else came in contact with. He passed out at the station. They gave him 3 doses of Narcan to bring him back, and then he was rushed to the hospital. So that's how serious this stuff is. It's something you got to be careful with, and when you're experimenting with drugs, this is something you really don't want to mess with, because it's eventually going to end your life. This is how we use data as far as Narcan deployments. We have direct access to LES, which is EMS, which is emergency services, and law enforcement Narcan. These are the numbers, 2014, how many times Narcan was deployed. The blue is LE, which is cops, and EMS is 4,632. If you fast forward all the way to 2017, look at how many times people have been hit with Narcan. And this is what we have this year in 2018, and we're projected to be at 15,000 Narcan deployments in the state, just on overdoses, which means somebody overdosed in the state, somebody's getting hit with Narcan to bring them back, and a lot of them don't make it. This is what you can see as far as Middlesex County. You can see where you're at, Middlesex County. What we do with data, suspected heroin submissions. We have access to the results of what departments submit heroin submissions for analysis, or suspected glassine bags on arrest investigation, or to fentanyl submissions. So we rate each county by how many they submit. And this is the ranking for Middlesex County. They're 10th out of the 21 with suspected heroin in Middlesex County. They're 10th out of the 21 with heroin and glassine bags that were seized at investigations or at sites where people were arrested for narcotics. They're 9th in fentanyl submissions out of the 21 counties. They're 9th in fentanyl glassines bags. The reason, and here where they started to get really low in the numbers out of 21 counties, they're 5th in opioid prescriptions. That means they're fifth as far as doctors prescribing opioids to patients in the state of New Jersey. And going all the way across, they're number 6 in the state of New Jersey as far as drug harm index, the possibility of being harmed by drugs in the state, where I think Essex County is number 1. You look on the last end, where's Essex at? Essex should be number 1. So it just shows how we use the data to let these counties know where they sit at as far as the drug harm index for their municipality. We also do more distinct products where we're going to a municipality and tell you what Patterson's like, specifically Patterson or municipality assessments in a sense. NJCares was started this year by the current administration, and this data is open to the public, so you can actually view it. You can log online and see that the overdoses deaths are 1,200 right now from January to June. Every month, we update it with all the data that we receive, so keep the public aware of what's going on with this epidemic. Naloxone administrations, we're at 3,987. Now, this number is a little, we have to add a caveat. We don't have hospital Narcan deployments. So if you're rushed to the hospital and you're already in the hospital and you've overdosed on something, we don't even have the numbers of what they're doing. So the number would be a lot greater if we had the emergency room naloxone deployments. We don't have those because of, once again, HIPAA. We're working on guidelines for legally to actually get that data so we can document this a lot better. And these are prescription drugs that are provided by PMP, prescription drugs that are given in the state of New Jersey this year. This is a HISN community we started at DMI, where you can actually log on if you're law enforcement, if you're science, in case there's any science people here, DMI law enforcement, National Guard, DMI prevention, DMI treatment. You can actually log on, and we have chat rooms. We provide information that will assist in educating the community on certain drug information. OD map, we were touching on this because we found a better way to actually document naloxone administrations with Baltimore HIDA, which DA is involved in that. There's an electronic format where we're going through the 21 counties. We'll eventually have MOUs where they can actually do a naloxone deployment, do it online, so we can have that information real time. So we'll know real time the person with naloxone. As of now, they have, I think, 48 hours to send us the information through a state directive, but here, as they do it, they can log on to their phone or their MDT and give us that information. The last few minutes I want to discuss is the drug harm index we spoke about, the quarterly reports we complete. That's all data-driven, the drug environment for each quarter. County drug assessments, every single county in the state by the end of the year will have a full drug assessment of what their current drug environment is, whether it's naloxone deployment, whether it's how many glassines bags are submitted to the lab. Well, that will be all in the county assessment. When it's strategic and there's a specific problem in a specific area, we'll go do municipal drug assessments. We'll even fine-tune it further into that police department, whether it's New Brunswick or Newark, and tell them what their drug environment is like. And then we also have the awareness products for law enforcement and society in general. Like, for instance, there's been, not a lot, but the new thing that's coming out right now is synthetic marijuana and lacing that with fentanyl. We don't have any proven cases yet, but that's believed to be occurring now, and we're following up and following that information closely. The biggest thing is the information sharing environment, what we have in DMI. Whatever data we have that we can provide, we will share with everybody. Law enforcement, public and private sector, different versions of it, because if we're going to combat this together, the best way to do it initially is for all of us to work together and share the information that we have. As I said before, our greatest partner is probably DEA in this format. We share information, we show up to each other's functions, and we're trying to support getting rid of this disease. DMI, our DMI unit has actually briefed these countries in how we do DMI. It was started in, like I said, 2014. It's spread worldwide. I think several states have it now. And several states, we've given them the actual formula to how we actually document this data. The other thing if I'd be remiss in not discussing, we have a lot of young people here in reference to opioids and the real effect it has. So I went to a seminar yesterday, opioid convention, and there was a doctor that was explaining how it affects us and why it's such a prolific problem. And the first thing he said, I think the best way to describe it is, we're all young, as people here, as a lot of young people, is sex. See the smiles on everybody's face when you mention the word sex? Everybody's like, and the reason I'm saying that is he found a real good way of explaining what it does to people. So the analysis on the brain of mice and rats and humans, and when they mentioned the word sex, I just said sex, and I saw about, everybody here was smiling, and some people were back, well, we're smiling, but not as much. So when you're in college, it's a whole different thing. Sex is a big component in life, so that's something that everybody wants, in a sense. I mean, if you don't, then I don't have to tell you, but normal people, when they're young, they want sex. So they had mice and they had human brain, and when the human brain, when you mention the word sex and they have your brain in one of those CAT scans, it lights up like a Christmas tree, because it's something that's pleasurable, you want it, you like it. You know, how many people would just say, you know what, no, I never want to have sex, ever again? It's not really going to happen. So with the mice, they give the mice food, which also stimulates the brain. So when the mice eats, it stimulates the brain, but when you have the mice procreate, the brain lights up a lot more. Then they introduced caffeine. So the mice tap a button, he's getting caffeine. He wouldn't go for the food, he would tap the caffeine all day, and would tap the caffeine 100 times more than he would tap for sex, which means for him, caffeine was more important than sex. Then they introduced heroin. He went to 200 times more. Then they increased fentanyl, 10,000 times more. In fact, tapped it so much, the mice died. And as the brain, you know, would get it, it would just light up like a Christmas tree. It's lighting up. So the addiction of this stuff is, what I'm trying to explain is that it lights up so far that you're going to want or keep pushing for this more until you die. I mean, who actually does that? Would anybody just say, I'm going to have sex so I can die? Nobody would say that, right? But with this drug, that's how addictive it is. And even with the treatment they have out there now, I've been through several seminars with every county, and they're sending people to 30-day treatments, and then they push it up to another 30-day treatment. Every time we've done strict liability death investigations where I've sat in a room, everybody that was there was hit with naloxone 2 to 3 times. Been in 2 to 3 30-day programs, then got upgraded to 60-day programs. So once you try it and you're hooked, it's extremely difficult to get off and save yourself. And you're not really a bad person. You want to do well. You want to stop. But it's like that mouth on that thing. Once it's in your brain, it changes the structure of how you actually think. Anybody under the age of 25, most people above 25 have this thing in their brain that makes them rationalize of what the consequences are before they do something. Under the age of 23, 25, you take risks. If you told me right now, hey, Fritz, just run across the street and see if the car's going to hit you, I'd be like, I'm 50 years old. Absolutely not. When you're 17, you're going to try that, because that thing in your brain with nothing to lose, because it's just you. Like, I have 3 kids. I'm not running across the street and get hit by a car with my 3 kids. So I have things that make me rationalize not doing it. When you're 17, you're exploring. You're trying things. You're 17, 25, you're enjoying life. And you're thinking this one thing, oh, if I try one time. You have that addictive gene, you're screwed. I mean, I'm telling you now because we're not on it, but it's going to affect your life so drastically, you can't help. Because here's the end result. You overdose. You get brought back. Now, you go to rehab. You relapse. You steal from your parents. They kick you out, move you to your aunt's house. You steal their TVs to go sell it. They kick you out. You go to your cousin's house. By the time you've relapsed the 6th time, you've already burned all your resources to support you. So now, even if you go to a 6-month program, when you come out, you're coming out to what? Right back in the same circle. And like that mice, if you have a dog right now, and I ring a bell, and I tell the dog to sit, he'll sit. If I ring a bell and I give the dog food after it, he's going to sit there and drool. Because after 3 months of ringing the bell, he gets food, he understands that the bell means food. The bell is not making him drool. The thought of the food is making him drool. See, if you've been on this stuff, which is 10,000 times more addictive, and you're in rehab, and you see fentanyl, you really can't control yourself. That's why it's being labeled as a disease right now. So it's something to think about prior to trying that one hit, or things of that nature. It's cheap, so the drug dealers would love for you to try it. because now they've got you hooked. It's got a constant mark. You're eventually going to die. I mean, what dealer wants to kill the customer? That's not the whole point. But in this case, it will kill you, and that's it.
Thanks, Lieutenant Colonel. I know that thing about people under 25 does not apply to our interns. You guys are all very sound of mind. Our final speaker is Linda Tartaglia. Linda is the director of the Center of Policing at Rutgers University, and she's an expert on information sharing and intel between law enforcement agencies. Linda's going to talk for about 10 minutes, and then we'll throw it open to questions from the crowd. Linda.
Can everybody hear me from here if I stay seated? I'm not doing a Okay, I'm not going to be speaking from a PowerPoint. Just a few comments about the Center on Policing. We were established in 2001 by Dr. George Kelling, and Dr. Kelling's mission at that time was to integrate research and evidence-based practices with the field, with actual police departments. So we work closely with the field, with state police and many of the local police departments throughout the state. About a year ago, the federal government, Homeland Security, I believe, Office of the Director of National Security, came to Cicada and wanted to form a research team to look at interoperability issues within the law enforcement and intelligence community. So we partnered with Cicada and many other people throughout the country to form a research team to look at some of the information sharing issues within the law enforcement community. So we began by surveying about 15 states and documented the process in which they share information. One of those states, Utah, we selected because we thought it was a very good example of information sharing. I personally traveled to Utah and met with various representatives of the federal, state, and local departments to talk about this one specific case study. By way of background, let me just give you a little sense of what the case was about. So a drug trafficking organization comprised of Honduran nationals had been active in the Salt Lake City, Pioneer Park area since 2012. They primarily sell heroin and cocaine. As Rick had mentioned earlier, the Sinaloa cartel have been linked to this organization because of there's a human and drug trafficking component to it that crosses the border into the United States. So just a real quick and dirty summary of the case, of the criminal activity, is the drug cartels go into the villages and start recruiting people and suggest that they make their way up to Mexico. And they do that through, I don't know if any of you have ever heard of La Vista. It's that train you may have seen on TV where people are hanging off the roof and out of the windows. It's a very dangerous trek through the country. They make their way to the border, where at the time they're met with handlers who then get them across into the United States. At that time, they are then paying off sort of their transport costs, and they become drug traffickers. One of the patterns that we've seen is like Pioneer Park in Salt Lake City had become a place where homeless people were congregating. So the drug traffickers tend to mix in with this group of people, so they're not easily detected. So that's really the sort of the crux of it. But I want to sort of explain to you how all of this unfolded and how the different agencies involved shared information, or what systems they used to sort of understand this whole case. So Homeland Security Office of Intelligence and Analysis assigns intelligence officers to the Fusion Center. You've heard, I think Rick talked about it, and our lieutenant here is now in charge of New Jersey's Fusion Center called the Rock. So there's about 78 of them around the country. They have this program where they assign their intelligence officers to the Fusion Centers. Now, this program is, in some states it's worked, in other states it has not worked. I'm not going to talk about New Jersey's experience. I will talk about Utah's experience. So the intelligence officer assigned shares national information to his federal representatives that participate in the Fusion Center. And they do this on a regular basis. As a result, and I think it was 2014, the intelligence officer received information from ICE ERO officers. They're the people that take people back to the country that they belong. Regarding a large number of Hondurans that they were selling, that they were seeing, they were being deported for selling a lot of drugs in this Pioneer Park area of Salt Lake City. And for them, an alert went up in their mind because sort of their detainee list had changed from what it was before, which was mostly Mexican, to now Hondurans. So in 2015, the Utah SIAC, which is the state, it's the ROC's counterpart in Utah. It's the Statewide Intelligence Analysis Center, launched and this is where the DHS intelligence officer sits, launched a working group, which included many of the federal counterparts and the Salt Lake City PD. At the time, DEA was not a participant. This working group discovered through the Salt Lake City PD that the majority of all the drug trafficking arrests were in fact Hondurans, and their records show this dated back to like 2012. They also realized that as soon as people were arrested, they were immediately being replaced on the streets with other Hondurans. So what they found was that there was a chain of people that were there was a group of people that were disposable because as soon as they were arrested, they went away, but they were immediately being replaced. So in their mind, this also showed them that they were connected to a much higher organized group of people. And they started looking at information regarding who they were connected to, and that's when they realized it was the Sinaloa cartel. So the SIAC, the Fusion Centers, have access to various databases at the state and local level, and through their intelligence officers and their connection to DHS, have access to various federal databases. At the local level, they have, because the Salt Lake City PD was involved, they had access to their records management system. Let me just step back now and talk a little bit about these systems. So Salt Lake City utilizes a platform called Palantir, which is I guess it's sort of the gold standard of how it fuses information. It's a very expensive system, but it has a very powerful analytical tool. That's what so the Salt Lake City PD had that, and they were connected to many other local police departments in the state. So that brought information together to the SIAC for them to look at. Just for your information, different parts of the country uses different systems. So like in New Jersey, I think we use the DIG, right? We're trying to fuse all of the local PDs through either the ROC or the Real-Time Crime Center. In Baltimore, Washington, D.C. area, they may use Maris. In In many of the other East Coast, we use RIS. So I just say that to let you know that there is not one system that local PDs are using to fuse all the information within their local PDs to bring up to the ROC for analysis. So that's something that we eventually are going to have to deal with in this country. And also, just to let you know, there's only 2 states that really are fully capable of sharing information, and that's Tennessee and South Dakota right now. So as a result of a lot of this raw intelligence and reports and local information, the SIAC and the intelligence and DHS were able to put together a picture of how the Hondurans were making their way from the country through Mexico and across the southwest border. The working group shared a lot of this information, and they finally got a new partner in DEA. So the new SAC and DEA was very supportive of information sharing, and he opened up their systems, DART, DICE, to the analysts within the SIAC, and that really sort of opened up the whole case. And then the local PD, with the assistance of DEA, started to do street operations, and they accumulated a couple of years worth of data, and then ICE started to do debriefings, and that information was included. So between this, what was a working group, and the agreements among many of the agencies to share the information, they were able to sort of put all of this together, or they began to put it together. At that time, in 2015, DHS wrote an IRR, which is an intelligence information report on the Honduran DTOs in Salt Lake City, and this went out nationwide to the intel community. This report was very well received. DHS has something called an IRR evaluation. When they think an intel product is very good, people will write an inval on it, and that means it's a high enough standard where the intel community needs to take this information very, very seriously. Because of that IIR, a lot of the Homeland Security databases and the Custom Border Patrol databases was reporting out nationwide different activity that they were seeing. As the information was shared beyond the working group, and I have to say, when I say the information was shared, information, even though we have databases, in the law enforcement community, information is shared once people know who you are. And you can't, we're not beyond, and I don't know if we will ever be beyond, emails, phone calls, and once we've developed trust, then our ability to share information increases. So through these nationwide, this reporting that came up from the local level up and then from the national level down, they recognized that that the picture started growing. In 2016, they issued a joint SEAL report. It was DHS, it was the SIAC, and it was the local Salt Lake City PD. And this was disseminated nationwide to all the fusion centers, posted on HISM, which is a federal database, and other intelligence community portals. It was distributed through the Rocky Mountain Information Network, which was Colorado's fusion center, which resulted in Arizona, Washington, Colorado, contacting them with additional information. So in response, this field, they also, the Joint SEAL report is called a Field Analysis Report. And once that went out and they got these responses, they realized that this was no longer just a statewide problem. They realized it even went, it was starting to go beyond a regional problem because of the Arizona, Washington, and Colorado information. And they also discovered that Denver, Colorado had the exact same experience as, recruiting from the villages, coming up, meeting handlers at the border, getting across the border, going into a city area where there was a large homeless population, integrating themselves with that homeless population, and starting to sell the heroin that way. After, as the case unfolded, Salt Lake City PD started monitoring jail calls. And from there, they made links to San Francisco and North Carolina. So now they realize it's not just statewide, it's not regional, it's national in scope. So that gives you sort of I'm not mentioning all the various databases, and what I guess I just want to highlight is that this is, many of these exchanges started from relationships, developed from an memorandum of understanding, and then started working closely together on a one-to-one basis. It also shows that fusion centers at the national level can really assist local public safety in identifying criminal activity and understanding it better. That's sort of, it's a real life study of what goes on in law enforcement in trying to understand the problem and how it has just sort of expanded throughout the country. Thank you.
Thanks, Linda. So we have a few minutes left for questions from the audience. I have a couple, but let's see what the audience members have on their minds. Any questions for any of our panelists? Okay, I'll get it started. So to Colonel Fuentes and Lieutenant Colonel Frage, the DMI data is compelling and it's interesting and it seems important to have, but can you give us an example of how this data is being put into use in a practical sense? Is it influencing or informing deployment of officers, identification of hotspots? How is that information actually being put to use on the streets by law enforcement?
Okay, I'll give you an example. We have a grant with Robert Wood Johnson Hospital, and we also work with Cooper Hospital down in South Jersey. So when they're giving out naloxone kits to opioid users, they will contact us, and we can tell them up to the 100 block number of where the overdoses are occurring, where the sales are occurring. So in this sense, if you're going to deploy a coach unit to New Brunswick, I can tell you within the 100 street block where the most overdoses have occurred in the past month, year.
And is that being used to inform deployment of state police or other resources?
It's being used to deploy the coach programs to assist with some of these overdose victims. It's being used in a sense, sometimes we use it for law enforcement purposes. If, like for instance, all the drug dealers name their narcotics by name, Red Lobster, right. Your Mama, they're all exciting names. And if there's an overdose of, like for instance, we had in Newark, we had 20-some people overdose within about an 8-hour period. Right. We found out that the drug was the one that was being used, I believe at that time, was Red Lobster. So we went into our glassine bag database to find out who are the dealers that are dealing with Red Lobster, and then we'll notify those local PDs and the state police and DEA HIDA that this is this is the one that's killing people. We need to get these guys off the streets where they can do enhanced investigations to get search warrants to actually stop this bad batch, as we would call it, from killing anybody else in the community.
One other question just for Dr. Majlesi. Can you talk about the PMP, the prescription monitoring program? Is that something that you have experience with in New York? And just sort of talk about your perspective. First of all, I guess explain briefly, if you could, what it is to the crowd, and then your perspective as a medical professional.
Sure. The prescription monitoring program is usually a statewide program, but there's a lot of collaboration within the states where you can actually enter patient data and find out how many controlled substances that patient has been prescribed in the past, I think it's up to 6 months. And so a lot of the states are also collaborating in terms of sharing that data. So as a physician who's prescribing a controlled substance, you're actually required to look at that database before you prescribe. As a primary care physician. It's still not required for emergency physicians and certain other specialties, but as a primary care physician, you are actually required to look that up. So, what was happening, before these systems were around was essentially patients were doctor shopping. They were going to different doctor offices, urgent cares, saying, I have back pain, dental pain, getting a prescription for 12 Percocets. And, by the time they were done with their day, they had 20 prescriptions for 12 Percocets, going to different pharmacies, filling them, and they'd have a big bulk of medications on their hands. So essentially what we're doing is preventing that. It's not the end-all, be-all, certainly not, the...
Is it mandatory in New York now? Because I know one of the things that happened a few years ago here in Jersey is we made it mandatory for all physicians to at least consult the PMP before prescribing.
It is mandatory for certain practitioners.
Right, okay.
Primary care physicians.
All right. Well, we are out of time, but everyone please join me in thanking our panel for a really informative presentation.